Thanks, Bob. Thank you guys for being here. Baltimore is actually not a bad place, so I hope you all have a good time. So my disclosure is I basically will work for anyone that pays me money. And the other disclosure is I tend to like to write textbooks, and even though no one buys textbooks and I make no money off of textbooks, they're still nice to do. But the best way of writing textbooks is you get to actually learn a lot, and you get to write them with your friends. And so that's the disclosure. So CO2 laser was ablative laser resurfacing, which first came out in the early 1990s. As Bob said, Dr. Fitzpatrick and I helped to develop it, and it still is a great procedure. In our clinic, we still do about 10 cases a week, so we're still doing a lot of ablative laser resurfacing, but there are potential complications. Dr. Tina Alster, who most of you know, wrote one of the first papers on complications, and of course people get erythematous, there's hyperpigmentation, there's acne from the wound healing response, etc. When facial edema, this is the biggest problem with laser resurfacing, is getting the patients to do the postoperative course. And so almost everything that we do is injuring the skin. And of course, patients will develop these basketball-like faces that can last for about a week or so. And it's proportional to both the depth, the thermal damage, and the inflammation. And those three things, the depth of penetration, nonspecific thermal damage, and inflammation, is what causes virtually all of the complications. Inflammation is not our friend, it's our enemy with laser resurfacing. But then also when we treat men and women, there is a difference. Men tend to do a lot better because we have thicker skin than women, but still we can treat patients from almost any age. And in fact, the very first patients we treated were children with linear epidermal nevi, as well as 90-year-old women with with squamous cell carcinoma. So you can virtually treat any type of skin. Again, necrotic tissue from the nonspecific thermal damage is what I think is the key, because it directly dysregulates wound healing and induces a number of proteases with inflammation. I put this slide up here because it demonstrates the amount of thermal damage that you see here from a CO2 laser, and this is 3 passes, which was a typical way we used to do the ultrapulse CO2 laser. And then Steve Mandy came to my office, and he's a really smart dermatologist who does a lot of dermabrasion. And he says, you know, Mitch, we don't see this inflammation and erythema after dermabrasion. And the reason is with dermabrasion, you do not get nonspecific thermal damage. So around that same time, the Erbium YAG laser just came out, and so I figured, okay, after we do our CO2, let's do Erbium YAG. The reason being Erbium YAG gives you almost 0 nonspecific thermal damage, and sure enough, we found a marked decrease in the nonspecific thermal damage in combining those 2 procedures. So again, when we use a CO2 laser, there is this area of ablation, which basically is the smoke that's hitting you in the face. And then there's this area of nonspecific thermal damage. And based on the power of your system and how many passes is dictating the amount of nonspecific thermal damage. So the technique that we do is to first do the CO2 laser, usually 2 passes, and then follow it with multiple passes of the Erbium YAG laser, which is essentially a tool to get rid of the nonspecific thermal damage. Again, I said there's a difference between men and women. So with women, usually we say you won't be going out to black tie affairs or lunch with your friends for about 2 weeks. For men, it's about 1 week. Again, there's a number of other important factors which makes it a little bit different between men and women, as I've listed here. One of the key questions I get asked is, should we be treating our patients preoperatively with anything to prevent some of the problems? And at least in our clinic, we've found absolutely no reason to pre-treat patients with depigmenting agents or anything else. But it does allow for you to test products that patients will be on in the post-op period. So even though it makes no difference in the amount of complications that you get, it still is a good idea to have patients start on some type of skincare before you do the treatment. So how do you minimize erythema, which is essentially minimizing inflammation? Well, one of the first things we did is we applied high-potency topical corticosteroids. Now, everyone said that I was an idiot when I started recommending that because, as we know, steroids can impede wound healing. But if you really look at wound healing, the steroids really don't make a difference on impeding wound healing till about 7 days or so. And so all of our patients are given high-potency topical corticosteroid ointments, just in pure petrolatum, to be applied immediately after the procedure for the first 7 days. A number of people have done studies on applying topical antioxidants. Jill Weibel published a really nice paper on using one of the SkinCeutical products. But if you apply topical antioxidants immediately afterwards, like even an excellent product like Phloretin CF, which is what Jill used, it's incredibly painful to do. So what we've done is we've treated patients with a pomegranate inula oil called Pomega, or elastin regenerating skin nectar. And then also there's a new sunscreen on the market called Pavis, which uses a very specific type of diamond core zinc oxide technology. And so those are what we like to use to try to minimize inflammation. There's a product called Aven, and they have this water which was first developed for the treatment of burn victims, and that tends to be work very well. And as Dr. Weiss mentioned in the previous lecture, the gentle waves also helps to decrease inflammation. Mario Trellis published a paper showing different types of cold light sources also tend to decrease inflammation as well. So we tend to see our patients back after laser resurfacing on a daily basis to administer these treatments. Now, as Dr. Weiss pointed out with the IPL, when you over-treat the skin, you can get hypopigmentation. And with laser resurfacing, that happens as well. Interestingly, with laser resurfacing, it's a functional disturbance in melanogenesis that really causes the hypopigmentation. And studies have shown that you do get this decreased density of melanocytes, but it's really problems with melanogenesis, which can last for many years, that causes this hypopigmentation. Greg Goodman was one of the first people from Australia who showed that you could do this autologous skin cell transplantation, which we've been doing for vitiligo patients, and that is probably the best way in order to reestablish melanocytes and melanogenesis to reduce pigmentation. Well, hyperpigmentation is the other thing that patients usually don't like. It usually develops at around 3 weeks or so and can last for 3 to 6 months. But the good news is it only lasts for 3 to 6 months. It occurs most commonly in our Asian patients because, as we know, Asian melanocytes are really weird and they react to anything. And so the good news is, as dermatologic surgeons, we treat them with topical depigmenting agents, and every single patient, the hyperpigmentation goes away, but it can take quite a long time. And these are some of the ways Dr. Alster first mentioned to treat this pigmentation. Now, it also occurs a lot in our Persian patient population, and this is one of our patients. Of course, she's the wife of a physician who developed the hyperpigmentation, but it goes away fairly quickly, and you can see that over time, the results are absolutely outstanding. So even though the UltraPulse CO2 laser, when it was developed, was a fractionated laser, because Dale Koop developed this handpiece, which allowed us to go either 1 millimeter apart to having the spots on top of each other. Dieter Meinstein and Rox Anderson came up with this concept of fractionated lasers, which allows for really untouched skin to be able to promote healing. And you can see in one of the studies that a retrospective chart review has a markedly decreased risk of complications or adverse effects than we saw with Dr. Alster's paper on confluent laser resurfacing. But you can get hyperpigmentation after fractionated CO2, as shown here. And when we did a study of our patient population treated with fractionated CO2 laser, again, the biggest problem we had was an allergic or contact dermatitis from the post-operative treatments, as well as acneiform breakout from, again, the post-operative treatments, but very little erythema. And this slide basically says the same thing. So fractionated laser, the less you ablate, the less complications you get. Scarring, of course, is the biggest problem that any of us will face. And again, it's primarily due to excessive thermal damage, but it's also, at least in our clinic, the #1 reason is infection. And that's why products like LaserSyn is very important for your patients to use because they can totally debacterialize their skin with just a few squirts. Now, I put up the Accutane because a lot of people think Accutane is a contraindication. It absolutely has no effect. And we've even treated patients with laser resurfacing who were on Accutane at the time with absolutely no problems. This is one of my patients who had an infection. She was a patient who was immunodeficient, and I failed to recognize that prior to the resurfacing procedure. And then on the other patient, on her chest, it's a different patient, had a pronounced infection with Pseudomonas leading to this type of scarring. Now, there are wide varieties of CO2 lasers, and it's not necessarily that one laser is better than another, it's how it's used. And so this was a patient who obviously had a too aggressive of a laser resurfacing, and this is a plasma device where in the proper hands it can be very effective, but in the Medi-Spa environment, not so much. The other problem that we see in laser resurfacing, especially if you're using the UltraPulse in the deep FX mode, is you can get these little laser imprints. But fortunately, these tend to resolve quite nicely using things like pulse dye laser and intense pulse light. It's delayed wound healing that really leads to the scarring, and so that's why it's so important to basically get the proper wound healing effects in order to treat our patients. And this is another patient who was treated elsewhere that had the scarring, but after a few pulse dye lasers and IPLs, she had an outstanding result. Another patient, again, treated elsewhere with a lot of scarring. Here we had to use intralesional 5-fluorouracil in order to treat the hypertrophic scarring. But it can also occur with fractionated resurfacing, as this paper shows. Stuart Nelson's actually in the audience. So patients can even get into trouble with fractionated CO2 lasers. This was a patient that my former partner, Richard Fitzpatrick, treated with an outstanding result with pulse dye laser and 5-fluorouracil and triamcinolone after this fractionated CO2 laser. So the treatment of scarring is a whole nother lecture, but essentially it's corticosteroids, 5-fluorouracil, pulse dye laser, and intense pulse light. And this is just one of the studies Fitzpatrick and I did like a long, long time ago, showing the best way to treat hypertrophic scars is the combination of 5% 5-fluorouracil as well as pulse dye laser. The concept is we're decreasing endothelial stimulation of type 5 collagen, destroying the excessive microvasculature, and altering the rate of collagen metabolism. And then another patient that I'm showing in here, this patient was treated with laser resurfacing in this area, but not this area. So after I got rid of all of her scarring, she still allowed me to do a laser resurfacing procedure on her to even out her entire face, which just shows you that it's not that the patient is just prone to scarring, it's the way the patient was treated. So these are two quotes by two really nice people. Mark Twain is the first one. It ain't what you don't know that gets you into trouble, it's what you know for sure that ain't so. And then my number one teaching that I tell all the residents is trust no one. Thanks, guys.